Good morning. My name is Dr. Kevin Ford. I'm a member of Omega Psi Phi Fraternity Incorporated, Gamma Pi chapter. And welcome to Gamma Pi's chapter's monthly health initiative, which covers medical topics that affect our community. Today's topic is glaucoma and common eye diseases. And we'd like to welcome our local ophthalmologist, Dr. Renee Bovelle, who will be the speaker for the topic today. Dr. Bovelle went to medical school at UCLA. She did a residency at Yale University. She did a fellowship in cornea and refractive surgery at LSU. She currently is a member of American Academy of Ophthalmology and American Society of Cataract and Refractive Surgery. Dr. Bovelle is also a member of the Divine Nine. She's a member of AKA sorority. And one of the things, welcome, Dr. Bovelle. I see you're on screen.
Thank you.
Good morning. Yes. And so one of the things, as I mentioned, Dr. Bovelle is an ophthalmologist. And as an internal medicine physician, a lot of patients come in and really unclear the difference between an ophthalmologist and an optometrist. And so an ophthalmologist is a medical doctor that went to medical school and did training and specialized in the eye. And they can do surgery on the eye, they can prescribe medication, whereas a optometrist, they've gone to optometry school and they primarily do refractive for glasses and so forth. So, but we today definitely have one of the top ophthalmologists here in Prince George's County, Dr. Renee Bovelle, and I'm gonna hand over the webinar to you.
Thank you, Dr. Ford. I appreciate being here and I appreciate the work that the Omegas are doing, your chapter is doing in educating our community. And as you mentioned, with ophthalmologists, we work closely hand in hand, as I do with you, with our patients. I'd like to work with the primary care doctor because many of the diseases that you treat, including diabetes, hypertension, high cholesterol, all can manifest in the eyes. And we're going to talk about some of those conditions today, in addition to glaucoma. Next. I want everyone to understand that you should enjoy good vision throughout your life. Things can change, and as things change, as ophthalmologists, we can help to address those changes and make sure that you continue to have good vision. I don't want people to feel that, oh, I'm a certain age, I just have to expect to have poor vision. Next. Some of the normal changes of aging include need for reading glasses, changing eyeglasses. Sometimes your eyes may become more irritated, and sometimes some of the external skin and tissue around the eye may change. Next. First, I'd like to start with a good understanding of the anatomy of the eye. The first, not most important, but part of the eye that people get confused about is the cornea. The cornea is the portion of the eye that people actually touch. You can actually touch your cornea, and you touch your cornea when you put on contact lenses. When you look at the center and you see that dark hole or the black center, that is the pupil. So you really can't touch the pupil because it's a hole in the iris. And the iris is what makes the eye and gives the eye its color. It can be blue, brown, or green. Behind the iris is the lens. The lens allows the eye to focus. When we look at something near, it almost looks like it's in a ball. And when we look further away, it flattens out. And your kindergartners, their eye can really, their lens can really go into a ball like that, and that's why they can read so close. We can't do that as adults. So that's why we need our reading glasses. And the lens is what turns into a cataract. We'll talk more about that later. In the center, you'll see the vitreous. That's a jelly-like substance. We'll be talking about that. And then lining the eye is the retina. And the retina has layers of nerves, veins, and arteries. And those coalesce to form the optic nerve. And we'll revisit this a little later. Next. Some of you may notice that you have a white ring around your eye. If that happens and you have it before the age of 50, it's important that you see your internal medicine doctor, such as Dr. Ford. The reason why is because that can be a sign of high cholesterol. In older people, 60s, 70s, 80s, it may just be a normal aging change. But if it happens when you're younger, it's important to get your cholesterol checked. Next. I also now would like to speak about the tears. The tears are not just water or a salt solution. They actually have molecules that help to keep the cornea healthy, help to protect the eye, help to ward off infection, and help to keep the eye nice and smooth and make it nice and almost oily so that when you blink, it doesn't hurt. Next. If your tears are unhealthy, you may develop a condition known as chronic dry eye. And this can occur as we age, in postmenopausal women, in certain medications, sometimes blood pressure medications, sometimes the water pill that you may need to be on, and also some autoimmune diseases such as lupus, Sjogren's syndrome, or rheumatoid arthritis. Now, with the medications that you may be on, and if you develop dry eye, don't stop taking the medications that Dr. Ford is putting you on. Absolutely not. We can work with you to make sure that we can mitigate the effects of some of those medications. Next. Some of the symptoms of dry eye are contact lens intolerance. You may find you can't wear your contacts as often as you used to. Problems reading. You may have a itchy or foreign body sensation or burning. And if you have glaucoma, sometimes that can predispose you to it. If you've had certain types of facial plastic surgery, maybe a lifting of the eyelids. If you smoke, anything, no matter what it is, just the smoke being around your eyes can cause dry eyes. And if you're diabetic, many of you are aware of diabetic neuropathy. Well, there are nerves in the eyes, and those can be affected by diabetes as well. Next. Oftentimes people come to me and they say, I have this tissue covering my eye. What is that? That is called a pterygium. And it occurs if you don't wear sunglasses, if you have a lot of irritation, and it can be treated surgically. It is a surgery. And we remove that excess tissue, and oftentimes it does not grow back. Sometimes it does, but many patients it does not, and people are generally happy with the outcome. Next. Before a pterygium covers the cornea, it may be small. When it's small like that, we call it a pinguecula. And again, it's important to wear sunglasses and protect your eyes from dust and the sun. Next. Arthritis, especially rheumatoid arthritis, has many common ocular manifestations, including dry eyes. The eyes can become red, that's episcleritis, or scleritis. You can get corneal ulcers, and you can get uveitis, which is inflammation of the eye. And rheumatoid arthritis is inflammation around the joints. And Dr. Ford can talk to you more about that. But that inflammation also occurs on the eyes, and these are some of the manifestations of that. Next. And you can see the eyes can become red in certain sectors. Sometimes they're blanched areas. And if you have something like that, it's important to let your internal medicine doctor know and also see your ophthalmologist. Next. Another common condition is thyroid disease. And a lot of people know your thyroid is right here in the neck. And oftentimes there are no signs, but sometimes the eyes can bulge. We call that proptosis. Sometimes it's hard for the eyes to look all different directions, up and down. And if you leave it untreated, it can threaten your vision. Next. And I think we all have seen people with the bulging eyes, and it's not just bulging eyes, but if you notice, this person's upper lid, the area above the upper lid, looks swollen. And usually, when you look at somebody's eyes, you don't see the white part or the sclera in the upper area. And if you look at hers appear to be bulging. So if you have that, there is something that can be done. There's new medication out there, and there's surgery that can be done. Generally, we like to start with medication first. Next. Now, January is glaucoma month, and I'd like to go over some of the risk factors. It's very important. As we get older, if you are Black or African American or African or Caribbean, you have a higher risk. Asian people have a higher risk. If you're nearsighted or you have a family history, and it's important to be seen by an ophthalmologist at least starting at age 50 once a year to make sure you don't have any of these risk factors and aren't at risk. And the concern with glaucoma is we like to say it steals your vision like a thief in the night, and you don't know until it's too late. Next. So one of the hallmarks of glaucoma is increased intraocular pressure. And the pressure is increased. It doesn't drain like it normally should. And that increased intraocular pressure reflects to the back of the eye and causes damage to the optic nerve. The way I like to talk to my patients about this, if you can imagine, if you have a light pressure on your big toe, not so much that it hurts, but just a light, constant pressure, what's going to happen over many, many years? That toe is not going to get the blood pressure it should, and it can, become gangrenous and then die, and you need to have it amputated. It's sort of the same thing with glaucoma. If you were to place a whole lot of pressure all at once, then you would say, ow, that hurts. But this is gradual, so you don't notice it. Next. When you come to the office, we'll do a visual field test. It looks similar to that machine, and it doesn't hurt. All you do is press a button every time you see a light. Next. And go back. Yes, there. That's good. Alrighty. And if you look at the picture on the left, you'll see the optic nerve, you'll see the rim, which is the pinkish orangish area, and inside you'll see the cup, which is the white area. The first picture, A, is a normal looking optic nerve, and next to that, you'll see a normal looking visual field. The middle picture, B, you'll see the cup looks a little bit bigger. And then the visual field that corresponds to that, you'll see some black area in that lower corner there, quadrant there. That person is starting to lose vision, but they won't notice it They will not notice it because it takes the vision from the periphery, so from the outside. And usually when somebody calls us, we look to the side to see if who's calling us or what's going on. So you don't notice the loss. And the final picture, you can see the cup is very large, and that person has a lot of visual field damage. It almost looks like a tunnel, and that's what it's like. It's like looking through a tunnel with severe glaucoma. Next, this is another test that we'll do. It's called a OCT. And with this test, we take a scan. It's just a scan. It's a picture of the optic nerve. And I liken this to a stoplight. When you see green, green is good, yellow is caution, red is not so good. And if you look at the picture on the left side and you look where it says OD, you can see there's more green and yellow. And if you look at the left side, which says OS, you can see there's a lot more red. And if you look at the picture in the lower right hand corner, you'll see a lot of red and yellow. That is showing where there is damage. Next. So now we're going to talk about retina problems. And retinal disorders account for about a third of all legal blindness in the United States. And that includes macular degeneration, diabetic retinopathy, and damage from high blood pressure. Today, we're going to talk about diabetes and high blood pressure. Next. Next, please. So some of the problems with diabetes affecting the eye are you get earlier cataracts, increased risk of glaucoma, and increased risk of retinal disease. Next. Diabetic retinopathy is a major cause of vision loss, and I like to work closely with Dr. Ford on patients who have diabetic retinopathy and diabetes. The most important thing that you can do if you have diabetic retinopathy is to listen to your internal medicine doctor, work with your endocrinologist if it's necessary, work with a nutritionist, and do everything you can, including exercise, just simple walking. That the best thing to do is to keep that blood sugar down. And I know we're coming out of the holidays and we've all been enjoying good food, but we have to watch out for diabetes. Next. This is what a patient who has non-proliferative, meaning a more mild form of diabetic retinopathy. And you'll see the optic nerve, but you'll see all kinds of red dots there. That's bleeding in the eye. You'll see all the white dots. That's actually lipid or oils that seep out of the blood vessels into the retinal tissue and cause loss of vision. And the retina gets its nutrition from blood vessels. And now this retina cannot get the nutrition it needs because the blood vessels are damaged due to diabetes. Next. And when the diabetes gets very bad, we get what we call proliferative diabetic retinopathy. What this is the retina is so undernourished that it sends out a signal and it tells the blood vessels, make new blood vessels. I'm not getting enough. I'm not getting enough nutrition. Make new blood vessels. And the body does that. But these blood vessels are not normal. And they're very weak and they tend to bleed. You can see it almost looks like a net, and those blood vessels bleed, and then your eye fills up with blood, and we have to do laser and all kinds of different interventions. So prevention is the key here. But if you have it, we can work with you. Next. Again, in patients who have high blood pressure, it's best to work with your internal medicine doctor, like Dr. Ford, to help keep your blood pressure down. So just like you can get a heart attack, the same thing can happen in your eye. The blood vessels in your eye can become occluded, and you can get an obstruction in either the vein or the artery. Next. This is what it looks like when you have a occlusion in the central retinal vein. And you can see it's almost like a hose. If you think of a water hose and the water's coming out of it and you try to hold it sealed shut, what's going to happen? The back area is going to burst and you'll get all kinds of water spurting out from the back area of the hose. And that's what's happening here. And of course, this person isn't going to see as well. And there are some interventions that we can do, but the most important thing is to work with the internal medicine doctor and keep the blood pressure at a normal level. Next. The same thing can happen with the artery, and it can happen either in a partial area can be occluded, and you can see in the first picture there that kind of whitish area superiorly is damaged, and in the next picture you can see the whole entire, again, this is a central retinal artery occlusion, the whole entire portion of the retina is damaged. And if it's a central retinal artery occlusion, unfortunately, there's not a lot we can do. We call that, it's like a stroke in the eye, and there's not a lot we can do. But if you have this is a warning sign. And I tell my patients who have this means that you are at risk for a generalized stroke. So we try to do everything we can to keep the blood pressure down. Whatever risk factors you have from stroke, you have to work with your internal medicine doctor and try to reduce those risk factors. So this is a warning sign. Next. Oftentimes, as we're here on the planet longer, you may hear people say that they have floaters. They may think that they see a little gnat or something, a little bug, and they look and it's not there. Or sometimes if they look at a white background, a white wall or clouds, they see little things floating around. Well, that is generally what we call a vitreous floater or posterior vitreous detachment. Earlier, I mentioned the vitreous. It's a jelly-like substance that when we're first born, it's the consistency of a raw egg white, and it's very sticky like that. And then over time, it becomes more watery, and we see things floating around in it. If you have that, if you see a whole lot of them all of a sudden, and especially if it's accompanied by flashes of lights, you should let your ophthalmologist know, because it could lead to retinal detachment. It's rare that that happens, but it could lead to it. And again, ounce of prevention is worth a pound of cure. Next. Good. No, right there is good. We can go back a little bit to where we're starting with cataracts. And we can go back. That's good. So a cataract affects the lens of the eye. And as we mentioned earlier, the cataract is in the middle of the eye. So it is not something that you scrape off. Oftentimes patients ask me that. No, it's in the middle of the eye, and it's a frosting or a clouding of the natural lens. And if you don't do anything about your cataract, you will lose vision, but it can be corrected. Next. And no, go back. That's good, right there. And cataracts can cause problems with routine daily activities. If you notice that you're having problems doing the things you normally like to do, uh, often my golfers out there notice first because they can't follow the ball like they used to. Colors can lose their brilliance. It may become harder to thread a needle if you like to do needlepoint, and it can be harder to read even and look at the computer or see street signs or highway signs. And this can occur rapidly or it can be gradual. Next. Good. One more back. And so what we do, you can see the picture on the left has a cloudy lens, and the picture on the right, we have replaced that cloudy lens with the intraocular lens. That's a synthetic lens. So we take out the cloudy lens and we have to replace it with a nice, clear synthetic lens. Next. Good. Now we're going to talk about IOL options. Until just a few years ago, we only could use a monofocal lens, which means one focal point. So you could see at the distance pretty well, but you see this picture, reading and mid-range distance looking at the computer was difficult. Next. Good. There. That kind of got everybody going. Now with multifocal lenses, you can see, looking at the picture on the right, you can see distance, near, and intermediate. And it kind of tries to mimic your natural lens, God-given lens. We can't do exactly what God did, but we can approach that. Next. The final step that we've been able to do to make cataract surgery much more precise and much more safe is using laser. Years ago, patients would say, is this done by laser? And I would say, no, it's done by hand. And yes, my hands are pretty steady, but my steadiness cannot approach that of a laser. So now we can use a laser to make the incision. We can use a laser to open the front of the lens, and we can break the cataract up into smaller pieces. That's called phacoemulsification. And then through that micro incision, we implant the lens. So the laser makes cataract surgery much more safer, much more precise, and we're even able to correct astigmatism with the laser. And that is very exciting. It makes your vision much better. And that concludes my brief overview of important diseases and conditions in cataract surgery and glaucoma, diabetes, and high blood pressure. Next. Thank you for having me, Dr. Ford.
Well, thank you very much for that interesting presentation. I think it was a lot of good information. One, we work together a lot of times in trying to help patients to keep their vision. You mentioned how important it was for patients that have diabetes, high blood pressure, to control those illnesses, right? And so, people can really lose their vision. And that's really what I was hearing today if you don't follow up. But a lot of times it can be prevented.
Yes.
Right?
Yes,
And
it's
so,
treatable. Just like the diseases that you treat are treatable. And it's really important for patients to understand that it is a team approach. You work with all of your doctors together But as the patient, I like my patients to understand what I'm doing, the reasons why I'm doing it, so that they understand why it's important for them to take their medications.
Exactly. And and glaucoma, I mean, it's really a pretty treatable disease, right?
Yes,
And tell me about some of the treatment. I mean, I know a lot of my patients are on drops, and what can you say about that?
sure. And I appreciate your letting patients know that it's important for them to get screened, and if they have a family history. That's another thing I'd like to point out. You know, a lot of us now we're looking at ancestry.com and spending money on all these tests and seeing, you know, where we're from. The most important thing you can do is get a good family history. Ask your parents, ask your grandparents what diseases run in the family. And even if you're not 100% sure of what they have, if they say they have some kind of eye disease, they lost vision, that helps us.
Mhm.
We can go from there. But I'm going to answer your question, Dr. Ford, but I want people to understand having any type of medical disease is nothing to be ashamed of. And, you know, back in the day, maybe we didn't like to say we had diabetes. We didn't like to say we had tuberculosis, but it's just usually a microorganism. It doesn't discriminate. It doesn't mean you did something wrong. It just means you have a microorganism that invaded your body.
Right.
So back to glaucoma. We are now changing the way we treat glaucoma. Years ago, we used to say, you have glaucoma, I'm going to give you drops, and you have to take these drops all the time. And it's hard to do anything, you know, 3 times a day, 2 times a day, once a day. You remember, did I take it today? Did I not? So now what we're trying to do is take the burden off of patients and make it a little easier. So there are lasers that we can use called SLT, selective laser trabeculoplasty. That's one way we treat. Another way we treat is with an implant called Durista. We place the medication at the target tissue.
Okay.
It's working 24/7 for the patient. The patient doesn't have to remember to take the drops, take the drops, take the drops every single day. And we all know January is a difficult time for all of us in medicine because that's when the insurances change. We don't know what medicines are going to be approved
Oh,
by the insurances. I know you go through this,
absolutely.
Dr. Ford, probably way more than I do. And it's difficult for the patients. And often patients go for a while, maybe without their medication. And that's not a good thing. So we're trying to work on things so they don't have to do that. But still, drops are a mainstay. And then sometimes we have to go to surgery. And there are now procedures that we can do at the same time as cataract surgery. Again, so you don't have to rely on drops as much.
And patients that have glaucoma, they usually have to follow up, I think, a little more frequently than just going for your routine eye. And tell me about that.
Definitely. I like to think of glaucoma as the high blood pressure of the eye. So I like to see those patients about every 3 to 4 months. If they're really doing well, we can go down to twice a year. But you remember those tests I showed you. So we have to get a visual field test twice a year. If they're doing okay, maybe once a year. So the visual field test is sort of like the EKG.
Mhm.
Get the EKG, that gives you an idea of how the blood pressure is going, how the heart is doing. Well, the visual field tells us if there is damage from glaucoma. And I'd like to point out that it's important to get the visual field because you have to lose half of the nerves in your eye in order for us to see it on the visual field. So I'd like to catch it before they lose half of their nerves.
No question. And it's just sad, speaking about glaucoma, I had a patient come in to the office, a new patient this week who lost their vision to glaucoma. So, and I've seen it a few times, and hopefully we don't have to see that ever again with all the different treatments, not only just using drops, but the surgeries that you can do to help to keep patients' vision.
It is very heartbreaking when I see that,
Yeah.
because once you've lost vision, we can't get the vision back.
Right.
And what we try to do is to preserve the vision that's there. And as you know, we have a lot of international patients here in our community. And what really breaks my heart is when I see a patient coming from another country, and maybe their children are bringing them here, and they say, hey, my mom or dad has cataracts, can you remove the cataracts? And I say, well, let me examine them first. And I examine them and I see it's not the cataracts that's causing the problem, it's the glaucoma. And if only I had been able to see them earlier, there's maybe something I could have done to prevent that loss of vision.
Yes, no question. You mentioned stigmatism. And I'm
Yes.
not sure what everyone listening understands what that is. Can you tell us about stigmatism?
Sure. Astigmatism is it 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 defines the shape of the cornea. And I know in the next couple of weeks, I think we're getting ready for a big football game. So I'd like to talk about it in terms of a football. You know, when you throw the football, the the tip of the football has a very sharp point, right? It's
Mhm.
it's a sharp curvature. And then the way the laces are going is a more shallow curvature. So the eye can be shaped like that. It can have a sharp or steep curvature in one meridian, maybe vertically this way, it could go like that. And then horizontally, it could be more shallow. A baseball, if you cut a baseball in half, it's going to have, it's perfectly round. The shape of the curve is the same in all directions. So if you have astigmatism, although this is an exaggerated example, it's like your eye is kind of shaped like a football. If you don't have it, it's like your eye is shaped more like a baseball.
Okay. Okay. Let's see. Well, Dr. Bovelle, I think we've come to the time where we're going to let you go today. We appreciate you coming on and giving us this great information. If you're in Prince George's County, Maryland, or even in the DMV, Dr. Bovelle is an excellent ophthalmologist who will be happy to take care of you, whether it's glaucoma, cataracts, diabetic retinopathy, and a whole gamut of eye diseases. And there's some other even, floaters. In fact, I had to come to you for floaters myself. And when you mentioned floaters earlier today. So again, I thank you. Gamma Pi, we give our webinars every month. Next month is Heart Health Month. And we have the privilege of having brother Dr. Edward Wingfield. He's an interventional cardiologist from New Jersey, and he'll be coming on talking about heart health. So again, I thank you and looking forward to seeing everyone next month. Thanks a lot, Dr. Bovelle.
Thank you.
All right. Take care.